Welcome guys to this Edison based discussion module, the thing that which is going on currently, and we are going in such a fashion that completion of MCQ will lead to completion of chapter. Currently we are going with rheumatology topic, and today we'll look into something very important in rheumatology from the Edison, that is sarcoidosis, right? And it is important for each one of you, whether you are final year MBBS student or medicine graduates or postgraduate completed want to complete Edison, it will be very much helpful for you, right? So we are going in such a fashion in this WhatsApp one-to-one group mentoring session where we are completing one chapter a day, almost a day, and our target is to complete medicine within a year, right? So if you are postgraduate residents, you don't have enough time to study during your works, or you are final year MBBS student, you want to complete Harrison in the form of MCQ, you are welcome, join here and let's study together and complete the Harrison. To join, the group link is given in the description, right? So today's our discussion topic is sarcoidosis. Sarcoidosis, remember, is a multi-system inflammatory disease. Now, in rheumatology, the conditions like SLE or RA, you can perceive it to be more of a something related to arthritis, right? Arthritis plus systemic manifestation. But sarcoidosis is something you cannot attribute to a single organ. It is a truly a multi-organ involvement disease. Although lung is most commonly involved, but invariably other organs are involved in sarcoidosis as well as you can perceive Sjogren to be a disease of something to eye or R, rheumatoid arthritis, a disease of joint. We cannot say similar thing for the sarcoidosis. It is a multi-system disease. All right. Okay. So coming to the first question of our day, it says a 44-year-old health worker with no prior lung disease presents with bilateral highland lymph node enlargement with non-causating granuloma. On biopsy, research suggests Propionibacterium acnes and mycobacterial protein molecule, namely by the name MCAD Okay, MCAD gene. Now, which is playing a role in granuloma formation. Which of the following best explain the current understanding of sarcoid pathogenesis? To understand the pathogenesis of sarcoid, okay, so first of all, remember when we need to diagnose a case of sarcoid, we need to at least have more than 2 organ involvement, right? To call something of a sarcoid. And one of the hallmark feature, as it has been mentioned here, is non-causating granuloma on biopsy. This non-causating granuloma, remember, is not something very much specific for sarcoid. It can be seen in other condition as well as. What are the condition in which this non-causating granuloma can be seen? It can be seen in case of TB, it can be seen in histoplasmosis, or for exam point of view, it remember it can be seen in something known as cat scratch disease or associated with beryllium exposure. Remember this 4 point apart from sarcoid where this granuloma formation can be seen. It can be seen in TB, it can be seen in histoplasmosis, it can be seen in cat scratch disease, it can be seen in beryllium, right? Okay, so this is a non-specific granuloma formation which is seen in this case, right? Now, what is it said here? It is said that what is the pathogenesis behind it? Now, we actually don't know what causes sarcoid, and we are yet to be known, and it is unknown pathogenesis. So, when something is unknown, we blame to environment, we blame to the gene, and we search infection to be triggered as to the disease, right? We blame to other thing that we don't know anything. We just say that gene is the issue, environment is the issue, right? So what are the factors in those among environment or gene or infection which play a role? So it has been found on research that some infection, for example, Propionibacterium acnes, are in very large number in the granuloma of the sarcoid, and even after introduction of this pathogen inside of a mice, it results into formation of the granuloma. Therefore, there should have some sort of role of this Propionibacterium acnes in formation of sarcoid granuloma. Similarly, Mycobacterium tuberculosis, mainly the protein of the MCAT-J gene, has also been found in very high number in the granuloma formation of sarcoidosis, right? So these are the two factors that we know which is associated with pathogenesis of sarcoid. Beside this environment, as you can see, the patient here was a healthcare worker. So environment of healthcare as well as as well as something associated with insecticide, environment of healthcare facility, or mold exposure has been found a direct role in pathogenesis of sarcoidosis. Similarly, some genetic factors do play a role. What are the important genetic factors in the pathogenesis? For you need to know only some of the few important name in it. So, what are those? These are HLA associated genetic factor, mainly HLA CD4 associated genetic factor has been found in the role. So, what are the names? You should remember the name of B1011. You should remember the name of B103 and HLA-B104. So, what are the rules, sir? HLA-B103 is linked with resolution. HLA-B104 has good prognosis, whereas HLA-B1011 is associated with increased risks of sarcoidosis. Okay. So, these are the environmental trigger, genetic trigger, as well as infectious trigger for sarcoidosis. Therefore, it is said that it is hypothesis has been made such that there are multiple agents which causes host specific granulomatous response resulting into sarcoidosis. So, correct answer of this question will be obviously the option C, that is host specific granulomatous response triggered by multiple environmental infectious agent in genetically susceptible individual. All right. Okay. So, talking about the immunopathogenesis, we have already discussed about the HLA markers. Now, what are the important thing you need to know? Beside HLA, there are important cytokines too in pathogenesis of this sarcoidosis. What are those important cytokines that you need to know? Is interferon gamma. In fact, interferon gamma is associated with formation of granuloma, right? So, beside this, there are also other cytokines. For example, interleukin 2, which is associated with calling the T cells, and TNF alpha that calls in the macrophages. All right. So, all of those cytokines, interferon gamma, interleukin 2, and TNF alpha, all together play a central role in pathogenesis of sarcoidosis. Now, one important point here it is seen in case of such disease is known as immune paradox. What is immune paradox? We'll come into this question and learn about it. So, what has been asked in this question? Here, as you can see, there is a 40-year-old woman is presenting with bilateral hilar lymphadenopathy, a key classical feature of sarcoidosis, right? And along with there is non-caseating granuloma. Again, it is of a clinical importance in case of sarcoidosis with peripheral lymphopenia. Tuberculin 10 skin test is negative despite prior BCG vaccination. So, this is about immune paradox phenomena. What is this? So, if we check into the hematological manifestation of sarcoidosis, remember most common is normocytic, normochromic anemia, right? Beside this, there is also lymphocytosis. However, these lymphocytes are inside the granuloma cell. As these lymphocytes are inside the granuloma cell, in peripheral smear, you don't get lymphocyte. Therefore, in peripheral smear, what we get is lymphopenia. That is also the key reason why this tuberculin skin test becomes negative even after BCG vaccination. So, this thing is known as immune paradox, where lymphocytes are accessed but all go inside the granuloma. Therefore, peripheral smear will have lymphopenia only, and this tuberculin skin test is coming to be negative because the circulating lymphocyte is low in the body. So, what is the correct answer here? Correct answer here is option B, that is peripheral lymphopenia due to sequestration of lymphocyte within the granuloma. Okay. Now, coming to the other option, you can see option 1, defective antigen presentation due to HLA DRB104 mutation. No, absolutely it is wrong. It is B1011 mutation which leads to sarcoidosis, right? Now, coming to interleukin 10, interleukin 10 production is associated with remission not with something to suppress or delete type hypersensitivity, rather it helps in remission of the disease. Okay. So coming to the next question, it is about the clinical manifestation of sarcoidosis. So what are the clinical features, how the sarcoid can present to you? So sarcoid, remember, very fastly can have a varied presentation, have multiple organ involvement, but we need to know about the what are acute organ involvement and what are chronic organ involvement. In acute organ involvement, remember, there are mainly two features. One is known as Lofgren syndrome. Another is given by name of the Herford's syndrome, right? So what are those? Lofgren syndrome is characterized by bilateral erythema nodosum. All right, number 1 point. Second point, along with bilateral erythema nodosum, there is bilateral hilar lymphadenopathy. Secondly, along with bilateral hilar lymphadenopathy, there is symmetric acute arthritis. So there is bilateral skin involvement in the form of erythema nodosum. There is hilar lymph node involvement in the chest X-ray, along with bilateral symmetric acute arthritis, that is Lofgren syndrome, and it is the acute manifestation of sarcoidosis. In most of the cases, around 20 to 30% of the cases, Lofgren syndrome can be totally asymptomatic, absolutely fine, only detected when there is chest X-ray feature suggestive of bilateral hilar lymphadenopathy, and they can have mild symptom in form of cough or dyspnea, and which resulted in delay in the diagnosis. Delay in the diagnosis because these are non-specific symptoms. Initially, they are shown to be any pulmonary complaint, but later on, only when there is clinical manifestation in the form of cutaneous skin nodes, which are tender nodes, erythema nodosum like nodes occurs, and which are symmetrical in nature, only the new suspect need to be sarcoidosis. Okay. So skin lesion will help in early diagnosis, whereas hilar lymph node will only delay the diagnosis. All right. Okay. So beside this, there is known as Harford's syndrome. What is Harford syndrome? Harford syndrome is characterized by bilateral parotid enlargement. Okay. So there will be bilateral parotid enlargement. What will happen when there is parotid enlargement? Our facial nerve passes through the parotid, right? So this facial nerve compression will take place, and this facial nerve compression will be at the infranuclear level. As there is infranuclear compression of the facial nerve, you will have element type pulsing, element type 7th nerve pulsing, and this element type 7th nerve pulsing will be bilateral because there is bilateral parotid enlargement. And third manifestation is uveitis, which is even one of the dreaded manifestation because it can lead to blindness. All right. Okay. So bilateral parotid enlargement, bilateral element type 7 nerve palsy, and uveitis, which may lead to blindness, is Harford syndrome. Okay. This is the usual manifestation of acute manifestation of sarcoidosis. So let's move into the MCQ. Here you can see a 30-year-old woman is presenting with similar features shown below, right? So what is the feature actually? You can see bilateral nodules. What do we call it? We call it as erythema nodules. All right. Okay, because it is reddish in color and it is a nodes like feature. And what along with bilateral hilar lymphadenopathy there is present on chest X-ray, there is bilateral hilar lymphadenopathy and polyarthralgia. What is it? It is nothing but Lofgren syndrome. What kind of manifestation is Lofgren syndrome? Lofgren syndrome is acute manifestation. Okay. So answer will be C, option C, Lofgren syndrome. All right. So what are the other structure mostly involved in case of sarcoidosis? Sarcoidosis mostly involved are lung, which is seen in 90% of the cases, and in follow-up, almost 95% cases of sarcoidosis will have any form of lung involvement. They can have simple nodular enlargement as well as patchy enlargement, patchy involvement of the lungs, right? Besides this, there can be skin involvement too. So Coming to the question, most common organ involvement in sarcoidosis. Most common organ involvement in sarcoidosis is nothing but lung. Okay, it is seen in 90% of the cases. Around 30% cases will have skin involvement, and skin followed by next will be eye involvement in 30% cases. That is, will have eye involvement in the form of uveitis. Liver involvement is seen in 20 to 30% cases in the form of mild derangement in liver function test, and 50% cases, if you go for biopsy only, you can find non-caseating granuloma. Brain involvement is very, very rare. Also, cardiac involvement is very rare. Cardiac is very, very rare. All right. So, what is the feature in lung? In lung, the feature which is seen is given by the name of scattering staging, right? What does it say? It say that lung involvement can be divided into 4 stages: stage 1, stage 2, stage 3, and stage 4. What are those? Stage 1 is only bilateral hilar adenopathy. Okay, bilateral hilar adenopathy. Stage 2 is bilateral hilar adenopathy plus along with patchy parenchymal involvement in the form of infiltration. Stage 3 is only infiltration, and stage 4 is when there is end-stage disease and fibrosis. In stage 2 and stage 3, they can have mild symptom in the form of cough or dyspnea, right? There can be mild symptom only, and in stage 1 sometimes they can remain as asymptomatic too. Later on stages, as the disease progresses, the patient can have restrictive lung disease. Almost seen in around 50% of the cases. Okay, all right. So this is about our lung involvement. Now, what is the skin involvement, which is seen in 30% of the cases? We have already discussed one of the important skin involvement, that is by the name erythema nodosum. Beside this, what are the important skin involvement can be seen? It is lupus pernio. Lupus pernio is chronic nodular lesion seen mainly in the cheek or in the nose. Erythema nodosum is seen usually bilateral symmetrical and associated with Lofgren, right? Beside this erythema nodosum and lupus pernio, there can be maculopapular lesions. Okay, so these are the skin involvement that can be seen in case of sarcoidosis. Now, regarding eye involvement, which is seen also in 30% cases, what are the eye involvement? Remember, anterior uveitis, just complete. Okay. Anterior uveitis is the most common eye involvement, and if anterior uveitis is not seen, second mostly seen is the posterior uveitis. This posterior uveitis is seen in around 25% of the cases. Okay. Beside this, there can be Sitka syndrome like manifestation. Sitka syndrome manifestation similar to Sjogren. All right. So this anterior uveitis can result into photophobia, blurring of vision, tearing, and sometimes they even result into asymptomatic stage. This is something that is worrisome for us because they may lead to blindness in patients. All right. Okay. So this is about skin involvement, eye involvement, and lung involvement in case of present of sarcoidosis. Now moving to the next question, it is about the scattering scoring. Here you can see a 45-year-old asymptomatic patient has a chest X-ray showing bilateral hilar lymphadenopathy without parenchymal involvement. PFT was done, which is normal. So because therefore this is a early disease. What is the staging and which is the most likely sarcoidosis stage in this patient? So as you can see, there is only hilar lymph node involvement. Therefore, it is nothing but stage 1 disease. All right. So let's move into the next question. Here it is said that a 35-year-old male presents with right-sided element type facial palsy, bilateral parotid gland enlargement, and red eye. So you can see it is a right-sided element type palsy, bilateral parotid gland enlargement, and red eye. What is it? Although bilateral facial nerve palsy is same, but in some cases unilateral element palsy can also be same. It is nothing but Hereford syndrome. What are the causes of bilateral element facial palsy? Is usually asked in exam. Remember, besides sarcoidosis, it can be also seen in MBBS. It can be seen in diphtheria, or it can be seen in Lyme's disease. So, sarcoid, GBS, diphtheria, Lyme's disease, these are the four important causes, important differential of bilateral element. Okay, 7 nerve palsy. Now, coming to the next question, it is about the liver manifestation of this disease. Here, as you can see, 38-year-old male with known pulmonary sarcoidosis is presenting with asymptomatic elevation of alkaline phosphatase. So, ALP is elevated around 3 times of upper limit of normal. USG was done which showed hepatomegaly, no biliary dilatation. Liver biopsy was done which revealed non-caseating granuloma. Do we actually need to go for liver biopsy in such cases? Not actually. This is MCQ patient only raised in alkaline phosphatase, nothing else. We don't need to go for liver biopsy in all of the cases, right? So, beside this, as it is a case of sarcoidosis, known sarcoidosis, remember 50% of the cases of sarcoid in biopsy will have this non-specific feature of non-caseating granuloma, and 20% cases of liver involvement will have raised in alkaline phosphatase without any symptom of cholangitis, right? There will be no itching, no other symptom of cholangitis. There can be mild hepatomegaly, mild cholestasis, or mild portal hypertension like feature. Cirrhosis is absolutely rare, and usually this manifestation, non-specific raise in alkaline phosphatase or hepatomegaly, responds to the therapy of sarcoidosis. Therefore, you don't need to know for go extra in it. As cirrhosis is rare, you don't need to treat extra, be overcautious in such cases of liver involvement. Just leave it around, it will get treated. How you treat sarcoid, this manifestation will go by you soon. And there is no requirement of transplant, absolutely no requirement of transplant in liver involvement case. Therefore, how do you treat it? Obviously, no need of immediate corticosteroid. First rule out whether there is organ involvement present or not. Only then you need to go for corticosteroid therapy. Ursodeoxycholic acid has no role in it. Observation with serial elective monitoring, that is the only thing that you need to do in this case, observation only. Right. Now, regarding option 4, ERCP to rule out PSC. Okay. So, as there is no biliary dilatation and no other feature of primary sclerosing cholangitis, obviously ERCP is not indicated in this case. All right. Okay. So, coming to next question. Okay, this is very important one. Here a 45-year-old male with known pulmonary sarcoid again is presenting with fatigue, polyuria, nausea. Laboratory test is revealing serum calcium to be elevated, vitamin D normal, 25 hydroxy vitamin D normal, 125 dihydroxy vitamin D to be elevated, 24-hour urinary calcium increased, and what is the most likely underlying mechanism for this hypercalcemia? Now, how do you approach a case of hypercalcemia? So, when there is raised serum calcium, first step is to check for corrected serum calcium level. If corrected serum calcium level for albumin also raised, because calcium is albumin bound moiety in our body, in our bloodstream, so you need to check for albumin level too. And if serum calcium corrected one is also raised, next step is to check for serum PTH level. If serum PTH is elevated, for all practical purpose, remember the cause is primary hyperparathyroidism. What does primary hyperthyroidism leading to? It leading to increase in the serum PTH level, which causes absorption of calcium from the body, increase in serum calcium. As serum calcium will be more, PTH level will be more, it will automatically suppress the vitamin D in the body, and ultimately low vitamin D will be seen in primary hyperparathyroidism. Now, things get interesting when PTH level is low. When PTH level is low, it means serum calcium is elevated in the body for non-PTH dependent sources. So, what can be the causes? It can be due to malignancy, number one. Malignancy, it can be due to granuloma, either TB granuloma or sarcoid granuloma, or it can be due to vitamin D intoxication. How to differentiate among them, right? So, for vitamin D intoxication, remember the storage form of vitamin D, which is 25 hydroxyvitamin D, will be high, right? Okay, and also the active form will also be high. 25 hydroxyvitamin D, that is the storage form, will be very high, and 125 dihydroxycholecalciferol will also be high. Okay, and what happens in granuloma? There is activation of 1-alpha hydroxylase, 1-alpha hydroxylase, which activates the body's vitamin D into 125 dihydroxycholecalciferol. Therefore, 125 dihydroxycholecalciferol will be very, very high, but vitamin D level will be normal, that is the storage form will be normal, or it will be in the lower side because these are getting activated and converted to active form. Okay. In malignancy, cases of malignancy, again, this can be divided into two types due to bony metastasis or 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 due to PTH related peptide hormone secretion of something known as squamous cell carcinoma of lung. When there is PTH related peptide secretion from squamous cell carcinoma of the lung, pattern is similar to the primary hyperparathyroidism. Only the difference is that PTH level will be normal. PTH level will be completely normal. Whereas in case of bony metastasis, there will be destruction of the bone resulting into increase in serum calcium level. What will be the effect of vitamin D? What will be the effect of parathyroid hormone? Both will be normal. Parathyroid normal, vitamin D normal, only there is raise in serum calcium. Now, in some cases, patient can have increase in serum calcium due to decreased excretion, and this is particularly seen in clinically in two conditions. One, which is a rare, but it is very important for exam and asked in NEET SS 2023 as well. It is familial hypocalciuric hypercalcemia. Another, which is very common clinically, commonly seen, is thiazide diuretics. In both of the cases, serum calcium level will be high, urinary calcium excretion will be low. How do you differentiate? You differentiate number one, with if there is positive family history, consider it to be familial hypocalciuric hypercalcemia. Number two, in case of thiazide diuretic, there will be not only problem with calcium metabolism, but problem with other electrolyte as well. There will be decrease in sodium, decrease in potassium, decrease in magnesium, but increase in serum calcium. Only in such cases, you will suspect it to be a case of thiazide diuretic induced causes. Okay, all right. So, coming to this question again. So, what is happening here? Here, serum calcium level is high. Serum calcium is high. 25 hydroxyvitamin D, which is the storage form, is normal. 125 dihydroxycholecalciferol is elevated, that is the active form is elevated. So, therefore, obviously there is action of 1-alpha hydroxylase, which is activating this vitamin D to the more active form, and also you can see other feature like 24-hour urinary calcium to be increased. Okay. So, what is the mechanism? Mechanism is external 1-alpha hydroxylation, most likely by the granuloma. All right. Now, let's move into the next question. But before moving to the next question, which is about diagnosis, I would like to discuss about the other rarer manifestation of this our discussion of today of sarcoidosis. Other organ manifestation we have already checked into the hematological manifestation in the form of anemia which is normocytic normochromic, or lymphopenia. We have seen the skin manifestation, we have seen pulmonary manifestation, we have seen liver manifestation, we have seen endocrine manifestation in the form of hypercalcemia. Now let's move to the rare one. What are the rare manifestation of sarcoidosis? These are two mainly you need to learn. One is neurosarcoidosis, another being cardiac sarcoidosis. Okay, so how to approach those? What are the important pattern? Remember, for rheumatologists, we have already seen there is LMN, bilateral, nerve pulsing. Also, there can be patchy involvement of the leptomeninges, enhancement of the leptomeninges, and there will be can be chances of lymphocytic, meningitis, where there will be mild increase in protein and to near to normal level of glucose level. And there can be as well as feature similar to multiple sclerosis. How to differentiate multiple sclerosis versus neurosarcoidosis? In case of neurosarcoidosis, there will be meningeal and hypothalamic involvement, which will suggest towards neurosarcoidosis rather than multiple sclerosis. So it will have meningeal involvement in case of neurosarcoidosis, or hypothalamic involvement, which is rare in case of multiple sclerosis, right? Now, regarding cardiac sarcoidosis, this is also a rare disease. Having said that, it can have patchy myocardial necrosis, which may lead to restrictive cardiomyopathy like pattern, or dilated cardiomyopathy pattern. But which is more common is debated topic. Different textbooks is different thing, but remember both can happen. It can have restrictive cardiomyopathy pattern as well as dilated cardiomyopathy pattern. Besides this congestive heart failure due to cardiomyopathy, there can be arrhythmia as well. Arrhythmia can be life-threatening in the form of VT or congestive heart, complete heart block. Right? And how do you diagnose cardiac sarcoidosis? Cardiac sarcoidosis is diagnosed with the help of PET scan only. Okay, so this is a very rare manifestation. Now, how to approach for diagnosis? Remember, there is not a specific diagnostic test to label a case of sarcoid. You need a compatible clinical as well as pathological finding to identify it a case of sarcoidosis. So, how do we usually approach? First of all, suppose a patient comes to you for a suspected case of sarcoidosis. Suspected sarcoidosis. It can be either that for some reason biopsy of any organ was done and pathologist found it to be non-casdating granuloma, and there is no other alternate diagnosis. In such cases, you can search for clinical history and label it as sarcoid, or there can be feature suggestive of sarcoid. For example, there is a chest X-ray with consistent feature of lymph node enlargement. There can be consistent skin lesion in the form of lupus spiny or erythema nodosum, or there can be uveitis along with optic neuritis involvement, or there can be something like elevated serum calcium level and cause is not known. In such case, obviously, you can go for biopsy of the affected organ and check for non-causating granuloma. If you get non-causating granuloma, obviously you consider it to be diagnosis. But if it is negative, but there is no other clinical evidence of any other disease and there is strong clinical suspicion of sarcoid, you go for other supportive test. What are the other supportive tests? Other supportive test is like serum ACE level. So what does serum ACE level helps in? Serum ACE level helps in telling us that if it is more than 2 times upper limit of normal, it is 2 times upper limit of normal, it is very much suggestive for us. Then again, bronchial with lymphocyte will be more than 2 times of upper limit of normal. That is also very much suggestive of we can get in a PET scan or gallium scan, we can get something known as panda sign or lambda sign. But these are suggestive feature, and if these are present, you can obviously consider it to be a case of possible sarcoidosis. All right. Okay. So that is how you approach such cases, right? Now remember, beside this, serum AC level, which we are going to do, if it is more than 2 times normal, we consider it to be suggestive. However, in a patient taking AC inhibitor, for example, if patient is on lisinopril, serum AC level will be low, invariably low, and it is elevated around in only acute cases 60 to 70% cases, and in chronic cases around only 20% cases will have high serum AC level. Therefore, it is a test with low specificity for diagnosis, right? But there can be cases of false positive, high cases of serum AC level. False positive can be seen in Gaucher's disease, can be seen in leprosy too. All right. Okay. And it can be also seen in TB. So it is not something very much helping you in diagnosing the case of sarcoidosis. Okay. And there is something which you usually do. It is the BAL CD4 is to CD8 ratio. And if it is more than 3.5, this is very much highly suggestive, for us for diagnosing a case of sarcoidosis. Okay. It is highly suggestive, but it is again less sensitive test. So coming to the question. So what is it says? It says a 40-year-old patient with suspected sarcoidosis undergoes multiple investigation. Which of the following finding is least likely to support the diagnosis of sarcoidosis? So chest X-ray showing bilateral hilar lymphadenopathy with axial calcification. Yes, hilar lymphadenopathy is a good marker. Initial sign of pulmonary involvement in case of sarcoidosis. PET-CT showing FDG with mediastinal lymph node. Okay, it is also a good sign. Bronchoalveolar lavage with CD4 CD8 ratio of 1:2. No, it is not. It is more than 3.5, which is suggestive. Serum AC level 2 times of upper limit of normal in patient taking lisinopril. What does lisinopril cause? It causes falsely low. So even if the patient is taking AC inhibitor, if serum AC level is more than 2 times of upper limit of normal, it is very much well and good. It is helping you, aiding you in diagnosis of sarcoidosis. Therefore, correct answer is option C. It is not helping you. It is least likely that the condition is sarcoidosis if there is only 1:2 ratio of CD4:CD8. All right. Okay. So coming to this, now we are going into the treatment of sarcoidosis. Before going to the treatment, you should know whom to treat and when not to treat, right? So what is the indication? Indication to start therapy in a case of sarcoidosis if there is organ threatening disease or you are suspecting an organ threatening disease in future and you want to prevent it, right? And why do you want to prevent it? Because you want to improve the quality of life. That is only indication in case of treatment of sarcoidosis. Now, in case of asymptomatic cases, for example, which we have seen just now regarding the liver manifestation, which was asymptomatic elevation of alkaline phosphatase, no symptom at all, mild hepatomegaly, patient's quality of life was absolutely normal. You can only go for without therapy and monitor the condition. You can go for monitoring LFT, you can go for monitoring chest X-ray if there is only chest X-ray lymph nodes, nothing else. No need to go for any therapy. Monitor for progression of the disease because it is a chronic disease, invariably chronic disease, and sometimes patient can be asymptomatic in 20% of the cases. Why to start steroid and give undue side effects to them? There is no point at all. So as we have seen, discussed that there are two types of condition in sarcoid. One is either acute condition and another is chronic condition. In acute disease, when there is minimal symptom or no symptom, just monitor. Okay. When there is mild symptom, for example, only eye involvement or skin involvement, try for topical therapy. If topical therapy does not involve, go for oral steroid, but low dose. When there is symptomatic major organ involvement, it calls for systemic steroid therapy, right? It calls for systemic steroid therapy. Usually, it is given in higher dose, later on reduced, gradually tapered to less than 10 milligram per day dose, and it is gradually tapered within 6 months. Okay, it is tapered within 6 months, and we need to continue prednisolone sometimes lifelong. Some cases, patient can have steroid-induced side effect. Okay, if there is steroid-induced side effect, obviously you need to withhold steroid and add a steroid-sparing agent. What are the steroid-sparing agent which you can add? You can go for methotrexate. You can go for azathioprine. And gradually start tapering the steroid dosage. All right. Okay. So this is in case of acute disease. In case of chronic disease, how do you approach? In case of chronic disease, if glucocorticoid is well tolerated and dose is less than 10 milligram per day, that is the required one, continue the therapy, nothing else. And if you can not keep the dose less than 10 milligram per day or glucocorticoid is not tolerated, you need to seek for alternative therapy. That is in the form of methotrexate or azathioprine. Now, alternative therapy can be methotrexate, HCQS, azathioprine, leflunomide, mycophenolate, mofetil, or minocycline, all of those. Among these, remember hydroxychloroquine and minocycline has good role in skin diseases. Minocycline has good role in skin manifestation of the disease. Okay. And sometimes glucocorticoid can be not effective as well. If glucocorticoid is not effective, you need to try alternative agent. If alternative agent is not effective, in such cases, you can consider biological agent like infliximab, cyclophosphamide, or thalidomide. All right. Okay, let's see the question. So what does it say? It says a 30-year-old female with skin manifestation of sarcoid present with the following finding is shown. Which of the following would be effective treatment besides steroid? Obviously, you can go for HCQS or minocycline because it is a skin manifestation. What kind of manifestation it is? Is bilateral reddish nodule. It is nothing but erythema nodosum. All right. Now coming to the next question. A 55-year-old woman with chronic pulmonary sarcoidosis has been on prednisolone 15 milligram per day for 6 months but continues to have progressive dyspnea and worsening infiltrate on imaging. Right. She developed Cushing-White feature and what features and osteoporosis. What is the most appropriate next step in management? So here you can see there is dyspnea is progressive and worsening infiltrate. Therefore, disease is still active. Secondly, steroid is ineffective. Thirdly, steroid dose is also more than 10 milligram per day. Fourth, there is steroid induced side effect. In such cases, obviously, it calls to add another steroid sparing agent first and gradually taper the steroid. So, answer will be add methotrexate and taper glucocorticoids. All right. Okay. Now, let's move into the last question of the day. So, what it says a 48-year-old man with neurosarcoidosis fails to respond to prednisolone and methotrexate. Okay. So, alternative agent has also failed. So, failed. MRI shows worsening leptomeningeal inflammation. Which agent is used? When there is failure of alternative agent, in such cases, we go for other agent or multiple agent combined together. Other agent, most likely we go for infliximab, biological, or we go for cyclophosphamide, or thalidomide. All right. Okay. So that's all about this MCQ discussion about the topic of sarcoidosis. Obviously, if you go through the chapter now, it will be very much easy for completion of the sarcoid chapter from the Harrison.